Good afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of hfma. The topic for today's webinar is Attacking Managed Care Denials, the New Battleground. This is part one of a two-part series. I'd like to welcome today's guest presenter, Egusquiza. Day brings over 30 years experience in healthcare reimbursement, hospital business operations, contracting, and compliance implementation. Additionally, her experience includes 8 years as a director of a physician medical management billing service, which included completing an integrated business office between a hospital and a large physician clinic. She's been an entrepreneur in hospital and physician practice accounts receivable management and a leader in redesigning numerous organizations. I've had the pleasure of partnering with Day on many educational webinars, live and in person, and she never disappoints. So without further delay, I'll pass the ball over to Day. Day, the floor is yours.
Thank you. It is, and Region 10 is my home region, so it's like being home when I get the privilege to teach with this great group. It is fun to be with you, and I am thrilled that we're going to be doing two webinars together, today and tomorrow. And just for people who may not have gotten this clear, this is actually, as Nikki said, a continuation. So I'll be teaching for about 50 minutes today, and then we will pick up new topics tomorrow, plus we have two great hospitals who are going to share some of their anguish. We're looking heavily at Medicare Advantage, but managed care period, but heavy Medicare Advantage just because there is such a huge influx of Medicare Advantage even into our very rural areas, and we have to beef up our game to be ready to be prepared to deal with this new market as it grows exponentially. So today we're going to talk about, I'm going to walk you through a couple hot spots today, and then tomorrow again as we get to the end, I will let you know kind of some of the main topics for tomorrow. So first of all, on slide 2, I want to bring to your attention, this one is the commercial that I said I have to be sure we get good at. It's called short-term health insurance. And those of you that are on my free info line, which, by the way, all you have to do is send me your email address. I'll be doing an info line in the next 2 days. And a lot of these updates that I teach in these webinars, I actually write up about them in our monthly updates, and all of our info lines for the years are posted on our website. So if there's any one particular topic that you may hear me say I wrote about that previously, please feel free to go out and get them. But you can go out on our webpage and send the email through that channel and get added to the free info line. The short-term health insurance is one I've written a lot about. Why? Well, you will remember the Affordable Care Act, which I hope you're doing education in your communities to teach people what that is. It's so hard to hear people say, I don't want it. And you go, well, do you know that you have individual coverage now and you have subsidies that could help you pay for the premiums, and there's the 10 essential benefits, and there's no waiting periods, and you do know that's all, and no caps on limits, and that's all in addition to the pre-existing protection. We never had this before 2008. So I don't know if we've lost it and kind of got wrapped up in all the rhetoric and we forgot to take a look at it, because the short-term health insurance is going directly against the Affordable Care Act because it can. President Trump passed, this slide's a little outdated, the state waiver that allows for if one plan on the exchange, remember that's where your individual plans are, or your early retirees can go get a coverage out there, or small employers can as individuals. So the healthcare exchanges, if you have one Blue Cross plan selling the full affordable care package, then you can sell short-term health insurance up to 3 years that have no protections in them. And so what we're seeing is, you can imagine what packages can be sold under the short-term health plan. So let's say Blue Cross. They can call it something different, Blue Cross Freedom. And in that plan, in your state, when your insurance staff are out validating benefits, you haven't had to look for pre-existing. You haven't had to look for waiting periods, or they don't cover mental health, or they don't cover drug treatments. The short-term health plans are like the extreme cafeteria plan. They literally, and they're all different, they can sell, and you would have, let me just give you an example. When I was teaching this in North Dakota's HFMA meeting last month, a lady, a great professional came up to me and said, you know, I just got laid off, and they offered me COBRA, which you do know that means you pay the full premium. Hello, you just got laid off. So she then said she went out to look at the exchanges, and somebody said, check out health, the short term. And so she did that. She called an insurance plan, and they were very clear to say, okay, if we offer you this, the premiums are going to be very low, but your package of benefits go with it. I mean, she told me she was even picking the drugs that she wanted covered. She had to guess what drugs she would need, and her son was in sports, so she had to figure out if that maybe she should ask for some sports coverage, and she didn't need maternity, and she didn't, but does she need mental health? Well, she don't think so. And so she literally picked a plan, very low premium, so she could afford it, but she knows she has literally no coverage if she really needed care. What are we being told at the national level? We're going to give you the cheapest health care there is. And unfortunately, with that comes no coverage. So in this example, this is a true example from Atlanta. This 40-year-old without a single man, probably a CPA, could have been a plumber, could have been an electrician, no group plan here. They got to go out to get it on the exchange. And he was paying $370 a month. He went out and got the short-term health package instead. Now he pays $47. Who wouldn't do that? Who would not do that? Healthcare providers, you are the trainers. You must educate your public what the Affordable Care Act really is. And these are scary things. We talk about it in DC like every patient understands their benefits. So here's my heads up. When you are validating insurance, you must teach your staff. Start looking for short-term health. Call your insurance brokers in your community. Are you selling this? Let me share with you what I personally have done. I'm a small employer in Idaho. We literally have no options. I have one plan to pick from. My monthly premium just went up to $1,350, a 70-30 plan with a $3,500 deduct for myself and my husband. That's our premium. We pay a $7,000 deduct between the two of us. Essentially, I have catastrophic coverage because by the time I meet my premium, I need to have some surgeries or stuff. So I have no options. You wouldn't believe what I've been looking to try to find insurance. So I decided to go out on the exchange as an individual. Well, I don't qualify for subsidies. I shouldn't. I'm not low income. So I'm left with $1,350 a month. Guess what I checked out for the first time in my life? I said, I want to look at short-term health insurance in Idaho. I can't believe I'm even saying this out loud, but that's $16,000 a year in premium for two of us, with a $7,000 deduct for two of us and a 70-30 plan. These are what small employers are up against. 92% of all employers in our country are under 50. How are we affording our insurance premiums? Those are the people who need to be heard in Congress, not the big employers. I mean, not that they're not suffering, don't get me wrong, but the 92% of us are dying with these premiums and the deducts. So even though the hospital industry may not support Medicare for all, may not support single payer system, whatever your own opinion is, you need to step back and say, the reason there's so much momentum is because of the premiums, and we have no break. There's nothing. You can't believe all the things I've been trying to find. Will I go with short-term health? This is interesting. When Idaho told me in Twin Falls that the Blues are looking at doing it, Select Health is looking at doing it, but they just don't know. And I went, what's your risk? You offer me nothing. So, but it's interesting to follow this. Now, there's some interesting stuff coming out. HFMA has written some articles recently about they don't think there's too big of a hit. It's because it isn't getting sold in every state yet, but it can be, and it probably will be. So what's your heads up? Pay attention when you're validating insurance. That's my message. And certainly help your public understand if it sounds too good to be true, it is too good to be true in today's world. Let's move to slide 3. Let's talk about some of the hot spots in the nation. This is that slide that I'm going to go to, your DRGs at risk, some payer audits that are going on, and some of our bigger problems. Let's move to slide 4. I am doing a free webinar with Compliance 360 this week, by the way, if you're interested in more on these managed care, Medicare Advantage anguish. But why did I start doing this whole world of Medicare Advantage especially? And our boot camp this year is Medicare Advantage. I mean, we have got to get ready. And look at this data. Every year, I do about 3 a year for Compliance 360. And every year I ask the question, who besides Iraqs are causing you grief? And without a doubt, I'm just appalled at this growth with the Medicare Advantage plans because we don't know how to deal with them as hospitals. We forget they're not Medicare, they're commercial payer. And of course, they make sure that you think they're Medicare, and they mix the words, and your poor UR case managers don't know anything what they're saying to them. And then contracting, are we contracted? What does it say in it? I don't know. Do you know where the contract is? That isn't even funny. I get that every day of the week. And then you have your commercial payers. How do we keep track of all these rules? Again, nationwide conversation we're having. Maybe we need to educate them. There's like 500 plans in this country and 500 different rules for inpatient versus odds, 500 different rules for a validation of medically necessary care. This is what you need to pay attention to and why our world has become complex. You might want to educate your public on what you deal with every day. Slide 5, let's talk about United. As you probably know, United gives me heartache. But United won a lawsuit. There was a lawsuit against the way, if you've not been following this, remember the Medicare Advantage plans are paid a per member per month amount based on like their diagnosis codes. I mean, how do you determine how much it's going to cost to take care of Day? You know, if I'm 65 and I want to sign up for United, United does this big workup on me, and then they do things like they may request my medical records to see if there's additional diagnosis codes that they can turn in and get a better payment in the big world of payment calculations. And so there was some whistleblowers against United saying that you are gouging, you're requesting all these records for no other reason than to try to up your own payment. You make diagnosis errors, and you shouldn't be paid for it. Slide 6, the court ruled in favor of the health plans, saying, because the health plans' argument was that the way the traditional Medicare gets paid on diagnosis codes, they're not hit with this overpayment rule, so why should we be? It's not our fault if the diagnosis codes on the bills are wrong. You can have your own opinion about that, but essentially it was dropped. So every whistleblower suit against the commercial plans under Medicare Advantage have all been dropped by the courts. You can all have your own opinion about who has power in this country. Okay, slide 7. Let's talk about CDI now. This one's a little dangerous. Pay attention. Probably most hospitals have some sort of clinical documentation. Make sure you use the word integrity, not improvement. Clinical documentation integrity going on. And most of us have done some training with our RNs to help them understand the world of coding. And we've done education with our physicians to try to help them remember to bring forward diagnosis codes that may be impacting their decisions, but they may not talk about it specifically in the record. We may have done some queries where we do not lead our physicians, but we do query them. Well, unfortunately, Integra has filed a False Claims Act against, unfortunately, Providence Health System out in the Northwest, stating that when they did their review, they had unwarranted major complications and comorbidity codes to inflate reimbursement. Their accusation is that they used this health system used a company which helped them figure out how to falsely upcode the records. We love that crap, don't we? And unfortunately, this is going to ripple. So what is the most important thing we can tell from this lawsuit? Whenever we are helping our physicians to tell a better patient story, that do not just list diagnosis codes, the physicians must speak to those codes. I'm sure you're doing that, because querying a doctor, say, hey, you forgot to mention the day has congestive heart failure. Well, then you better talk about it and treat it and include it in his assessment and ongoing progress notes, not just, hey, list these diagnosis codes, because that's getting us in trouble across the country anyway. This lawsuit is going to probably have some ripple effects. Make very sure that you're teaching your physician how to make sure they bring forward any kind of clinical information attached to any diagnosis codes, and that you are reviewing those queries to be very sure there's no leading in the query. Let's look at slide 8 and let's start talking about Medicare Advantage plans. This is where I want to spend quite a bit of time in this particular session with you. Medicare Advantage, we used to call it Managed Medicare. We'd call it Part C. When I started doing community education as part of our foundation we formed in 2017, one of the things that I did was I was out doing education with a bunch of local great seniors, and I kept calling it Managed Medicare, Part C. And after my first little while, a lady raised her hand and she said, what are you talking about? I have Medicare Advantage. And I went, well, okay, that could be why you and I are on 2 different pages. I think, and then I have been co-training with sales brokers, insurance brokers, who do nothing but talk Medicare Advantage. Here's some more advantages for being part of Medicare's alternative program that is not traditional Medicare. The Medicare Advantage, we anticipate 50% of our market will be in the Advantage plans. Congress, you should hear them talk about the Advantage. Man, these guys know how to direct patient care. They know how to limit excessive services. They know how to make sure that no excess Medicare dollars are being spent for unnecessary care because they're managing the care of the Medicare patient. They love Medicare Advantage, guys. Heads up. Go back and read yesterday or the day before. We're going to save Medicare by moving it under Advantage. I wouldn't have a problem with that. And if we remembered that we still have to have a payment for inpatients, we still need to be paid for drugs and ongoing cancer care. So there's such a disconnect between the correct payment systems for Medicare Advantage as a commercial payer, i.e. managing the Medicare market. This is not at all like traditional Medicare. They get the plans are paid per member per month, but they also at the end of the year, Humana, turn on the TV. My husband just called me and said, hey, Humana's commercials on TV about, what is it, silver slippers or something? They want you to know it's not a supplement. Get healthy. And I said, yeah, they need you healthy so they make money off you. Because if you get sick, they got to take it out of their pool of money to pay the healthcare provider. I get this. And the more I watch TV, the more I understand the marketing of it. And who in their right mind wouldn't want to be part of a Medicare Advantage plan? As I turn 65 in a couple of years, I'm like, lightning's going to strike me. I might sign up for one because I get glasses covered, hearing aids covered, memberships covered. They now have things called supplemental care benefits, that you hear about. They go into the home. They have a care manager attached. And then the patients score the managed care plans, and they get these massive bonuses called the STAR system. So we're going to talk a lot about this at the boot camp, whether you can join us in DC in July or you're going to sign up through our live web streaming. We're going to talk about this. So you understand when you're talking to a Medicare Advantage plan, most of them are commercial payers, but we're teaching us how to become an MA plan as a provider. You can be one yourself instead of being a victim to them, and how your patients realize why would they sign up for a Medicare Advantage. But the patients can't have a supplement, so they have more out of pocket, but their monthly premiums are less. So it is not a traditional Medicare program. The minute you sign a contract, Medicare traditional rules have now been set to the side, and whatever the contract has in it is primary. If you do not contract with these payers, you do not follow their contract rules, you follow traditional Medicare rules. And we have two speakers talking about this because this has been a huge need. CMS Medicare oversees the Medicare Advantage plans, and they were aghast to find out that there are hospitals that don't contract. Well, why would you? Why would you contract to take this massive reduction in payment, have massive costs fighting over every inpatient, every lab, every MRI, every drug, and your patients over there going, why are you doing this to me? I have Medicare. No, you have Medicare Advantage, which is a commercial insurance plan administering a Medicare benefit that they're paid totally different than a traditional Medicare. So on slide 9, here's some other things that you need to be aware of with your Medicare Advantage market. Medicare plans are county specific, and they create communities. So only certain plans are sold. So if you're I'm just going to give you Idaho. We've been doing all these boot camps this is a different kind of boot camp, but it's our Medicare 101 boot camps. And the insurance broker says, we don't even sell in the county of Gooding, but we sell all around Gooding, but not Gooding. And I said, why aren't you selling in that county? Well, there's not enough people in the county to make it worth our money, kind of deal. No, of course not. But that's a community. So your in-network is a community of hospitals and doctors. So if you're a snowbird or you plan on going to spend time with your kids and you're on ongoing therapy or lab tests, you will be out of network if you're in an MA plan. Your MA plan is right where you live. If you've got to go 2 hours to another hospital, you're going to be out of network unless that hospital 2 hours away is in your community network. You got to learn this stuff, and it's been painful as I've learned it because I watch it happen, and of course loved ones and friends and so forth. You also have to decide, why would you contract? if you're the only healthcare provider in the middle of nowhere, why did you contract? Because contract means you're going to take less than bill charges. You're going to take less than, if you're critical access, have you accepted less than the Medicare per diem rate? If you're a DRG hospital, have you accepted less than traditional? And then why would you go through all the cost of all that prior auth? Why would you go through all that cost? And where are the patients going to go? Drive 40 miles, 60 miles to the next hospital? You have to sit back as cause, especially critical accesses, and you got to figure out, why are you contracted? Especially if you have cost incurred. To be out of network, you cannot. Remember, here's the big line I want you to see. Those MA plans have to have a provider network to sell in your community. They can't sell if they don't have the hospital. They can't sell if they don't have primary care, cardiologists, internal medicine. They can't sell then. And you're going to hear tomorrow about one of our hospitals that kind of got that backwards. They were selling their little heart out and marched into the hospital and said, yo, you want to sign? Because we got all these covered lives. Well, they're not allowed to do it that way. You turn them in. I'm going to teach you how to file complaints against MA plans with traditional Medicare, who oversees the MA plans. And your patients can, general enrollment is once a year, and they can opt out through the end of March. That's been a change. So patients need to understand what they have. Who's helping them in your community? The insurance agents? Really? How about hospital revenue cycle people? Who better to teach this than us? Yeah. Take a look at slide 10. Here's the financials behind why patients would take Medicare Advantage over traditional. And again, I spent time with my insurance broker, who's my co-trainer on this stuff, because he's amazed that all this stuff goes on in hospitals and physicians. Of course, they don't know it. They just sell it. Good people, but they don't know it. So when I start doing the math, why would you switch? Well, traditional Medicare has a Part B monthly premium of 130-ish, income-based. Part D is 80 a month, has to be paid, you guys. They don't have a choice of these two. And then traditional Medicare, many of our patients get the Medicare supplement to pay their copays and deducts, which is about 180 a month, with no cap for out-of-pocket. They just keep spending their out-of-pockets. If they don't have a supplement, then hopefully you would help them get into the Medicare Medicaid savings program for our low-income seniors. And who's helping them get that revenue cycle? Yo, that's you again. You need to help our patients know where resources are, because they certainly won't. Now let's talk about a Medicare Advantage plan. What they're doing is they're collapsing Part A, where there's no premiums, Part B, where there's premiums, Part D, where there's monthly premiums, and they collapse them all in together and sell it as Part C, and usually the monthly premium is less than Part A, Part B. And then you add the supplement. So, your parents, me, as I get 65, I could be paying about $350, $390 a month. If I go to a Medicare Advantage plan, I will be paying much less than that, but I will not have a supplement. So I would be paying out of pocket for my inpatient deducts and my Part Bs, but there's a cap on how much you would pay. So an example was $6,700 as a Medicare Advantage. Now remember, every plan can do it different. I have a friend in Chicago who's my guinea pig, because she just moved from traditional Medicare to Medicare Advantage. She said, Day, I'm on a United plan. And she said, I'm not paying a monthly premium hardly at all. They're waiving them. And I went, wow, how's that legal? But they're waiving them. And she goes, and that's, of course, they're getting this massive market share, but their per member per month they're getting for her must offset to make it worth it to really have many. And so a lot of these managed Medicare plans can offer less monthly out of pocket, because remember, it's all collapsed into a single payment. Man, I'm telling you, who wouldn't want this? Except community doctors, and the doctors have to be in the community network. And of course, in Chicago, I have no problems with this day. My hospital is in my community network. My doctors are in my community network. The only problem I have was trying to get a prior auth to have a lab test done on a cancer, not the lab, the treatment. And she said I had to wait 2 weeks for them to come back and make a decision. I had to get a prior auth, which I never would have had to do with traditional. She said, so right now I'm okay. I have another person on a Medicare Advantage plan. One of our auditors sent me a note this morning. The prior auth has told her they will not do an MRI on her knee until she has 2 weeks of outpatient rehab. And she said, well, my knee is so swollen, according to my doctor, I can't even move it. Well, they won't do an MRI till they find out if she can fix it through PT. So she'll be paying for PT, and now she's very upset with her MA plan, going, how is this possible? I can't do this. So my guidance to her is there's a way to file a complaint. It will impact their star ratings, but you got to be sure you really aren't rehab potential. And her physician and her are working on this together. Traditional Medicare wouldn't have had to do that. But you can understand why when you're trying to save the Medicare, which is slated to go Part A is slated to go bankrupt in another 5 to 6 years, they will love Medicare Advantage, because as frustrating as it is with these two stories, it delayed care, didn't it? It made sure that this care is really medically necessary, whatever that means. And so pay attention. It was less upfront cash for these patients, but when they needed care, one of them is struggling, the other one not so bad. Traditional Medicare wouldn't have worked that way. So then let's talk about some of the oversight of the Medicare Advantage plans. I'm watching my time. These are called risk adjustment data validations. If you remember, the RAC auditors were supposed to be auditing the managed Medicare. They've only been around, Medicare Advantage plans, like 2000-ish. They're very young. Traditional Medicare has been around since 1965. So when you realize it's time to buckle down on these Medicare Advantage plans, and they're starting to be audited, and unfortunately, they haven't had, you can read this, it's going to upset you when you read it all, but the way the risk validation, remember, they go in and they look at those diagnosis codes, and the oversight company, CMS, whoever they hire, oversight of the RAC, through the RAC auditors, were supposed to look at these Medicare Advantage plans. Well, if you look at this one, this was an audit that was done of a regional Medicare Advantage plan, and they found that 55 of the 100, the sample they did, the diagnosis codes were not supported in the record. Now remember with the lawsuit, it's not our fault those are wrong. Well, then you were paid based on those, and then when they asked for 55 of 100, the records didn't support. You mean the hospital had that high of an error rate? Really? Really? Or possibly, maybe. So there was some, when they extrapolated, they found they owed $423 million. This was in 2007. In 2017, if you want to look at the bottom of slide 12, this is going to make you unhappy. These are under intense pressure from the insurance industry. CMS, remember, who oversees all MA plans, quietly backed off their repayment demands and settled the audits from 2012 for just under $3.4 million, shortchanging taxpayers $125 million in possible overcharges just for the 1 year. How many of you, when you have and you've been identified by the RACs or by the QIOs that you have an overpayment, did you get to hold your money for another 5, 7, 10 years? No, really? You mean they recouped it? And then you had to file an appeal to get it back maybe and get settled 2 or 3 years, 5 years later? Not the way it's working with the MAs. So the Government Office of Accounting was highly critical of these oversights of the MAs. So I would tell you, we've already heard that the MAs are having 75% more inpatient denials than traditional Medicare. Well, you know, it depends on your perspective. See, all those traditional Medicares weren't medically necessary. Or the only way you're making money off Medicare traditionals is you're never getting an inpatient. They'll give you a 7-day obs stay. This is why we have to beef up our game so we know exactly what our contract state, medically necessary inpatient, what does that mean? It is nothing more than a way to deny you. So you have to be able to be really sharp on this stuff. So let's go to slide 13 and let's talk about some of those. First of all, patient status on slide 14, DRG downgrades and readmissions. In our session, we're not going to get through all 3 of those today because I want to allow a little Q&A time, but let's get through our slides for today and then we'll continue tomorrow. DRG downgrades, slide 15. This one is tough, and so we have to be sure as a revenue cycle leaders that we're working with our HIM leaders and we're tracking and trending. Now, in my world, I don't call these denials. I think, you know, when CFOs call me and ask for help, it's like, I got so many denials. And I'll say, can we talk about what you really have? Do you have disputes, downgrades, and denials? Because a DRG is downgraded. If they strip the comorbidities off, which is what the managed Medicare plans are really good at, sepsis always makes us crazy. But let's say they strip them off. Then the question is, didn't you get a DRG payment anyway, though? You just didn't get the comorbidity add-on that you deserved. I don't call that a denial. Denial means you didn't get anything. These are downgrades. You lost your comorbidity. Who's tracking and trending that? By payer. so that you have that kind of, and of course you're appealing these, right? And you get frustrated going, I mean, I get stuff from you folks all the time. I'm loving to help you every way we can. But some of our challenge is to say to you, you have an attorney, right? Keep a log and start filing formal complaints. Oh, this is a commercial plan. File a formal complaint with the Department of Insurance against them. You really don't have to roll over and accept it, though I've done this for 40 years, and how many years did the Blues and, and the Pacific Sources and Aetnas and so forth, they would say something to us, and we're like, okay, we don't have any choice. Just remember, anytime somebody says medically necessary to you, I want you to just sit back and go, that means nothing, nothing. Tell me what you really are saying. That there's no documentation in the record to support sepsis? Try again. It's on this slide and this page. Oh, you mean you're using a different definition? Because sepsis is making us crazy. What's the definition of sepsis for United? Where is it in writing? Where? Oh, you mean Blue Cross is using a different one than United? Where does it say that? Oh, Medicare is using one that's different than United. And okay, where does it say it? You've let yourself be subject to the sepsis crazies because you haven't stopped to say, where does it say in our contract what you're using? And did I agree to that? Instead, I just had a great call with an Iowa hospital yesterday. That's all we talked about. And so I kept going, tell me what your contract says. Oh, it's on their web page. It's on their policy page that they update all the time that nobody knows is happening. Is it over there? Did you agree to that? Then you're going to have to change your internal buy. Well, but Medicare's is different than United's. Then you have two sets of rules, guys. You did it to yourself. Well, we can't do it that way. Yeah, you can, because you signed it. Medicare, you signed anyway. So the sepsis crazies is making it's very difficult, but you have to know what you're dealing with. And I'm only using sepsis because unfortunately that story I just gave you is true. So on slide 16, we have to know what's happening by payer, by diagnosis. What is it? Track and trend. Are we trying to do, remember, peer-to-peer phone calls for DRG disputes are happening after we're paid. So that peer-to-peer is becoming non-existent once the payment has been made. So you're into a formal appeal with most of your payers. We used to be able to have a doctor, your doctor, trained, talking to the payer's doctor, questionable trained, and you talk about why you're right. Where is it in the record? What are the correct coding initiatives? Where is it that made you right? And you used to just kind of talk about it on the phone and try to convince them. Now your payers have come back and went, once we've made a payment, we're not talking. Just file an appeal. Yet another reason you must track and trend and decide whether it makes any sense for you to continue to contract in this environment, or whether you say no more. And you go tell your employers, you tell your docs, you tell everybody why you're making these decisions with good, substantial data, not horror stories, because we all have those. Slide 17, how about those requests for records? Again, know what's in your contracts. We are such creatures of get a record request, send it, get a record request, send it. And then, I hear about, you hear about, this is unbelievable. We had 60 records from ABC Insurance. And last month they sent us 60 and they want to look at, and they're telling us Medicare says they have to do it. All right, first of all, that's not true. Second of all, Medicare makes them self-audit to be sure that what they're doing is right, but you have incurred a massive cost for sending all those records. And what was the value? Remember the HIPAA privacy payment. You've already got payment. So what do they want those for? Are they looking for diagnosis codes to increase their payment per member per month? Why? And what does your contract say? I'll have to tell you, we just did this in an upstate New York hospital. It's a 3-hospital health system. When we were there, one of the things that came up with the request for records, and I said, well, what's your contract say? And they all looked at me like, I don't know. And I said, well, that's the only wrong answer. So that night, they went hunting for contracts to see if they couldn't find them. And they came back the next morning and just kind of chuckled, and they said, you won't believe what we finally found when we found the contracts on the record request. We had put down that they could ask for 60 every 6 months. They'd asked for 600 in 1 month. And they'd already sent 1,200 like 5 months before. And nobody was holding these guys accountable because we are so siloed. Medical records, somebody get your hands on your record request and make them tell you why they need those records. What does it say? Did you just sign that they could ask for any records because of medical necessity? Which means nothing. What are they looking for? So as you become more in tune with this, you can hold feet to the fire and say, let's agree to what you need to look at and why. Oh, you're looking at outliers? What are you looking for an outlier for? You only paid us a DRG anyway. Oh, you want to give us more money? How about it? I'll send you those records. Okay, you can all stop laughing now. Slide 18. And then how many of you have had lost medical records? Some of you have started, of course, for years and years and years, you were supposed to send them certified with the signature required. And then, of course, when they said they didn't have them, the signature was, well, we have no idea. That was in the mail clerk. It never got to my office. So then we are electronic, and we go, let's put it on a secure portal. And then you have to dial into the secure portal so we can see you got it. And they're like, well, still didn't get it, send them again. And so we are so siloed that the send again on the EOB that got denied for technical denial for no sending of the record, you're jumping up and screaming in the revenue cycle. And the medical records is over here saying, we sent that twice already. And everybody's screaming, and you forgot the person you should really be screaming at is the payer. And under the HIPAA privacy law, you have all the power in the world to say to them, you are in violation of HIPAA privacy. Are you going to turn yourself into the Office of Civil Rights, or would you like us to? This will have been the third patient that you have, quote, lost their records. We have proof you have them, and you have lost them. This is not a payment issue now. This is you protecting your patient's PHI, protected health information. Absolutely, positively do this. It is not hard to file a complaint out on CMS, the Office of Civil Rights webpage. More than anything, you're letting your senior leaders know, you're letting your contracting people know, you're letting your attorneys know. If you don't squeak, nobody else will do it for you. So a couple things here on slide 19. This is a huge win. Two big wins here. The first one is, again, Medicare Advantage did you know they have a manual? I never knew it, never had a need to know it. Medicare Managed Care has a manual, and in their manual it says, Chapter 4, I believe, under medical necessity, if the plan approved the furnishing of a service through an advanced determination of coverage, it may not deny coverage later on the basis of a lack of medical necessity. This is your get out of jail free card forever. How many of you are getting requests for records 2 and 3 years later? A new company, they hire a vendor. United hires Optum or companies like them, and they come in and audit you a year later and say, oh, wait, not medically necessary. They only stayed a day, so give us back our inpatient DRG payment. You're like, no, too bad, so sad, dudes. We were approved inpatient on the initial ER to inpatient visit. That's where the inpatient happened. And because the patient recovered faster than expected, you don't get our inpatient back a year later, 2 months later. You already approved it. And you must use this. This is your only and turn them into Medicare on a regular basis. We also have an attorney who believes that the MA plans must follow the 2 midnight rule because of this particular piece of the guidelines to be an MA. So again, would you like to get away from the crazies of every MA plan gets to decide what their definition of an inpatient is? United is using MCG, the old Milliman. A lot of Blues are moving from Interqual to Milliman. What are they using? They can't just use their best guess. Or I'm telling you, some of these things that we get to see are a little disheartening for me because I say to the hospital, and what are you doing about this? Well, they're not going to pay us, so we're just going to have to get used to getting odds. And I'm like, and you think you're going to stay open? You are going to be in financial distress in a heartbeat. So Medicare Advantage plans have a definition in their contract of medically necessary inpatient. You must say, and what does that mean? They're using clinical guidelines. They all are. You've got to hold their feet to the fire that makes them abide by their own rules. And then once, if you're in a contract and they have given you prior authorization for inpatient, they don't get to come back later, hire an outside company who gets paid a percentage of what they take back, and you can never roll over, ever. You've got to become much more, and who has the manpower? I get it. You're exhausted. I am too, just teaching this. But, for 20 years in my old hospital, I was exhausted then. I can't imagine how hard it is for us now. Slide 20, let's talk about those peer-to-peer phone calls. Your insurance companies have decided that they're not going to let a trained physician advisor speak on behalf of the patient. They want the attendings. They want the treating physicians. You must challenge them on this, because what's happening is there's a way for, and especially under Medicare Advantage plans, there's a form, and Dr. Baker knows this better than I do. There's a document that can be signed that you could probably, there's a formal document, but I'm sure you could create one that tells Humana that your physician advisor, Dr. Joe, is acting on behalf of the patient to dispute their inpatient determination. Because what they've said is in their bylaws, in their policies, that they just put up these updates. Humana just did it, and it's last year, and said, we're not going to talk to anybody but the person providing treatment. So you sign a document that says, my trained physician advisor who's been trained how to talk to payers, he's doing it on behalf of the patient. Not the doctor who's directing care, but the patient. And this is when they can't do they have to talk to you now. Because remember, the patients who this is all about, even though we get a little crazy with some of this, it is our patients who we're doing this on behalf of. And then on slide 21, here's some more catchphrases that I'm going to talk you through here a little bit. I only got about 7 minutes left. Contracting. Remember that the contract with the Medicare Advantage, is they always throw this in, hospital are covered when Medicare criteria are met. Everybody's got it in their contract. And then they turn around and make you do prior auth for everything. And then they turn around and don't honor the 2 midnight rule. But they are, on slide 22, they are starting to say, well, hey, condition code 44 for traditional Medicare says that you can't change a patient's status after discharge. So for traditional Medicare, if you're supposed to get inpatient versus outpatient OBS sorted out while they're in your building. And of course you can do this, and you must do this, because you're not sending records or anything. There's no excuse for you not to get that done correctly in-house. But for Medicare Advantage plans, you're sending records. You're sending them to United and Pacific Source and Select Health and pick one, Blue Cross. And what if you're in a dispute with them? See, this is where we dispute, the second D, we dispute inpatient versus OBS. We're disputing that they gave us OBS and we have inpatient according to their criteria called interqual. And so then you're in a battle, and you send the records off and they send back OBS, and you go, no, we demand a peer-to-peer phone call right now, payer to payer, our physician to their payer physician. And so you set this call up and you try, and it takes 2 days. And because you have nothing in your contract, you should have put something in there that anytime there's a peer-to-peer request, it's responded to within 8 hours, and the call is scheduled within 10, something like that, because grandma's going to get well and go home, or well enough. And so grandma goes home, and come Monday morning, here comes the phone call. And so let's say you're battling with Humana over inpatient, and your physician advisor and your UR nurse goes, you know what, we're going to give this one up, because we got these 2 over here we're going to win on inpatient, but this third one, let's give them OBS on this one. Then Humana says, and by the way, since we're doing this after grandma has been discharged, you can't do condition code 44, which only applies to traditional Medicare anyway, but they're telling you can't change your status, so essentially you have to do a denied inpatient, labs and x-rays, $150, you don't get to bill OBS, and you lose hugely. So my question is, why'd you let them get away with it? You have to say to them, no, you either go by the 2 midnight rule, you don't make us do all these prior auths, and yeah, we'll follow Medicare criteria, or you forget, we don't use the rule of can't change after discharge, because that's not traditional Medicare. You're not doing traditional Medicare, Humana. You have your own rules. You use interqual, you make us send records, all that delays, we have peer-to-peer battles, and then we may or may not give it up. You don't get it both ways, guys. You're either traditional or you're not. And of course, you decide which battle you want to win. So on slide 23, I'm just going to give you a couple examples. Again, the biggest payer in the country is United, so you better pay attention. I would suggest that this goes for all payers, but this was an advice from one of our physician advisors. Always make sure you have in your documents the reason for the denial for inpatient. What was the criteria they used? Because you've got yours. You've got United, which is using MCG Milliman. And if you're using interqual, you're going to lose. Make sure you hear me. Well, Dave, we've got United and Blue Cross, and Blue Cross is using interqual, and United is using MCG, which traditional Medicare uses neither. They use the 2 midnight rule. So you bought MCG, but Blue Cross is using interqual. You will lose trying to get an inpatient because you're using the wrong criteria. Do you have to buy both? I hate to say that, but depend upon who your market is. So if you've got one United a month, you may not win this one, or you've got 50 United and 50 Blue Cross. You can't have one set of criteria unless they're both using it. You should ask, what is it that you're using? See, there's your justification. This is United's, but you can say, I want to know what criteria you used. And then slide 24 is we have, I think this is Humana. We have two different companies here. This is South Carolina, but they're saying they will no longer take peer-to-peer unless you have a contract. So kind of getting reminded there, aren't you? And then last but not least, on slide 25, this is when I shared with you, this is a real example, 3 years after they have an outpatient procedure, they had a history of the syndrome, failed 48 hours of outpatient treatment, inpatient was approved with the payer prior to the billing 3 years ago. Now they've hired this outpatient company, this third-party vendor, and they're taking my inpatient. What did I say? No, no. You have your attorney have this letter ready. You pop off the thing right out of the Medicare manual. You say you're in violation of this. You file a complaint with CMS on slide 26. You file a complaint because that's in violation of the law, and they're getting away with it because hospitals are just not good at this yet. And I'm not saying we're going to be antagonistic, but they don't get away with doing that, and they're all doing it because hospitals don't know any different because we're so conditioned. So these are how you file complaints. So mostly I want to tell you how to, we'll do it again tomorrow too, but on slide 27, I want to show you, this just came in from this great, she's going to be speaking at our boot camp again this year. It's an 80-bed hospital. This poor compliance officer, she files appeals, she files complaints, she is a working machine. And last year she talked to me about an Aetna problem. And I recommended that she, number one, Medicare, before we file a complaint, they will ask you to always reach out to the plans, Aetna in her case, and United, and give them a chance to do the right thing, which she did. So Aetna, when she filed a formal complaint with CMS, within 30 days after receiving the complaint, Aetna reached out and settled the accounts. Like within 30 days. The accounts were already a year old. United was another issue. They were cooperating with her about what was going on and trying to get these two accounts resolved from over a year ago. And suddenly they just stopped returning her phone calls. They wouldn't return her letters. They would do nothing. Both of these were behavioral health, both of these over a year old. And so they just stopped, and so she said, I'm going to file another complaint against you if you don't reply, which they didn't. So then in March she did. You realize the cost of all this? 15 days after she filed the second complaint, both accounts were paid. Not only that, they were paid with interest because she didn't have a contract with United. So guess what happens without a contract? Traditional Medicare rules apply. So because it took them more than 60 days to pay, they had to pay her interest. And you're going to love this. The Part C advocate, those complaint people over there on the previous slide, she made them send a letter to the Illinois hospital explaining why it took so long to remedy this. It works when you squeak, but you must do the right thing with good examples, give the plans a chance to correct, track and trend, keep track of it, and then make sure that people in decision making know the cost. She said at the end of this is her CFO and CEO were so impressed they couldn't believe this was actually happening. They were like winning. And she said, because it's wrong. And she's going to speak at our boot camp again this year, and she's got lots of stories to tell from a little 80-bed hospital. I don't know how she said it's a battle to stay solvent with all this going on with these payers. Well, because I said I would finish, and I'm right on time. If we switch to slide 28, let me give you a couple things. I do the free info line. If you want to get added, there's my email address. If you want to find out more about our Groovy Boot Camp coming up, that's how you can get it. And remember, we're the only ones that offer critical access pricing, and near and dear to my heart. And we also have live web streaming, which we're the only ones in the country with TV cameras running. So you can be with us even if you can't afford to travel to DC. So the big discount, early bird discount ends the 31st. So again, This is just us trying to bring you the message in every way we possibly can to help us get ready for the 50% Medicare Advantage especially. Now tomorrow, a couple things while you get your questions ready. Tomorrow, we're going to be continuing on, and I'll be talking more about readmission anguish, right? And we have our two great hospitals are going to talk to us about what they've been going through, two distinct examples, and then they're just going to share with their PowerPoints. And then we really would love to have any of you on the call, if you feel comfortable, sending us some of the anguish you're having so we can speak directly to it. You can key it in as a question and it can be carried forward to us for tomorrow, or even tomorrow if you want to. But if you can give us a chance to see your situation, it'll give me a head start to help you with an answer, but it may also help our two additional presenters tomorrow with theirs. And having said that, I think I'm ready for Q&A, Nikki.
All right. Thanks so much, Day. As I mentioned, you always deliver. So thank you so much for sharing that with our audience. Before I take our first question, I just want to remind everyone to type their questions into the chat panel located to the right of your screen, and we will take as many as time will allow. I will go ahead and address one question about accessing the replay. So today's session was recorded. In fact, we'll try to expedite the packaging of today's replay in the event that you want to share this with someone before joining tomorrow's part 2 session. All right. It looks like, okay, so here's a question that came in earlier during your presentation. It's regarding the clinical documentation. You mentioned that integrity was preferred over improvement, the use of those two terms. Could you elaborate on that?
Sure. Anytime this is just semantics a little bit, but let's think of the message. We have, remember in the revenue cycle, we used to call it cash improvement or revenue integrity. Now it used to be revenue improvement. And so then the public maybe perceived that we were just trying to find ways to make money versus true integrity of charging. The documentation supported the charges. We now have revenue integrity in the revenue cycle. Coding integrity. It's coding clinical documentation integrity. You are teaching how to improve the documentation to support what's actually going on in the record, not just to find more money. And CDI, if I were to walk into a CFO's office and say, tell me why you like CDI. Man, my case mix went up and the DRG payment's so much better than it used to be for that particular diagnosis. It's groovy. I think the better answer might be, and I would help my CFO, I would say, that may be true, but isn't it really great that our record more substantiates the true patient story? And our physicians are doing a much better job of wrapping in those diagnoses into their actual documentation to support it. And now our records become bulletproof. They become audit proof. That's the value of the CDI program, as in integrity. Just make sure the message is clear what we're doing it for. A better patient story, more complete patient history, more complete wrapping it all together. And yeah, maybe we get a couple extra bucks for all that. But if the money is the driver, it's the wrong message. And so by changing the title, and I do hear this, I have at our boot camp and our pre-con, I have one of the great guys, Dr. Bundridge, talk about CDI, and it's very much CDI as in integrity. And I had another one at our training I was just at, and she did the same thing. These are physician trainers who are saying, let's change the title. Let's change the way we think and the way we present it, and maybe it'll be a better picture all the way around, especially now with these lawsuits.
All right, thank you so much for that. We have another question coming in. It reads, if we have a Humana contract and recently added an orthopedic surgeon for inpatient stays, they are only paying per diem. Should we consider renegotiating our contract?
Well, I would say, what size hospital are you? If you're critical access, traditional Medicare is paying you per diem anyway for inpatient stays, excuse me. So the question would be, what size hospital are you? I would think that any time you need to take a good hard look, total needs should get everybody's attention. Traditional Medicare took it off the inpatient only list. What did your managed Medicare do? Did they take it off too? That's Humana. What did managed Medicare, Medicare Advantage do for total needs? And you better know what they've done, because they're going to say, we follow Medicare criteria, and so they took it off. and now you're trying to defend it. How do you defend an inpatient for a total knee when they don't use the 2 midnight rule? How do you defend it? You have set yourself up to fail badly. So I would definitely look at the ortho business line. I would look at what your costs are if you can do it. But if not, I would still look at what does the managed Medicare, Medicare Advantage, Humana contract say about the inpatient only. It'll say, we follow that. Groovy, it's not on it anymore. So how do I get an inpatient for my total knee? I know how to tell you how to do it for traditional Medicare. We have 2 out on my website. There's a class called Inpatient versus OBS plus Total Knee Anguish. Traditional Medicare has given us 2 really nice gifts. One is a guideline and one is a MedLearn that you should be following religiously in your documentation. What did Humana have? How'd you get an inpatient out of them? So renegotiating is one thing, but step back and look at those total needs as it relates to your contracts with your Medicare Advantage.
All right, thanks so much for that. All right, this next question is, will UHC ER level of care policy be discussed? So perhaps in tomorrow's session, is that part of the topics?
It really isn't. So why don't you send it to me other than that, because I know what you're talking about, but why don't you send a little note and we can plug that in. That would not be the level of care that they're auditing now is horrific. The ER level of care, I'm assuming you're talking about the facility leveling where you essentially have to use their product to pass their audit, and they're looking and downgrading based on their criteria, not yours, which is, did you sign off on that? Did you agree to that? So yeah, send me a little bit more and we'll definitely, because I teach it in my disruption class, which is also on our webpage. So there's another class for you that's free out there. It's called What Does Disruption Look Like? And I think we just updated that last week, and it has all about the United's audits of their ER level of care. So, but we'll sure talk about it if you want to send me maybe your specific issue, and we can grab that one tomorrow.
Awesome. That's very generous. And Dave's contact information is on the screen. And we will go ahead and address one last question. Oh, this is an easy one. Just asking if the webinar, will you get a copy of the recording? So we normally send this out within a couple of days. As I mentioned earlier, we will try to figure out a way to expedite this just so you guys can either watch it again if you joined late and want to share this with some of your coworkers before getting into part 2 on tomorrow. So we will make that a priority. So I know that we only have about a minute left. As we approach the top of the hour, I just want to take this time to thank our members and the healthcare community for joining this call. A couple of quick notes. As I mentioned, today's session is part 1 of a 2-part series. If you have not signed up for part 2, which takes place tomorrow, I have placed the registration link in your chat panel. So just click on that and save your spot and you'll be good to go. Also, as you exit today's webinar, you will be prompted with a survey, and we would greatly appreciate you sharing your feedback about today's event as well as some other topics that you're interested in for future webinars. Thank you again to our guest presenter, Dave Egusquiza of AR Systems. Any last words that you'd like to share today, Dave?
No, I'm thrilled. This is a great kind of education. So I am thrilled to be a part of it, and we'll tackle stuff tomorrow, and I'll look forward to getting anything else you may want us to try to approach. We'll get that through Nikki. And thanks again for letting me be a part of this.
Awesome. Thank you. Thanks again, everyone. Have a great afternoon.